Greetings and welcome to your customized deep dive. Today, we are immersing ourselves in a single vital chapter from Brunner and Sutter's textbook of medical surgical nursing, focusing intensely on the comprehensive assessment and management of patients living with obesity.
And that chapter is just so foundational. The scope of this disease, both in the United States and globally, it's really reached pandemic proportions.
So it's something every nurse is going to see.
Every single nurse, regardless of their setting, be it critical care, primary care, or med-surg, you have to be prepared to manage these patients with both precision and, a lot of compassion.
Okay, so what's our mission today?
Our mission is to transform this critical clinical text into an actionable, clear framework for you. We're going to guide you section by section through the etiology, the detailed assessment tools, medical management, surgical interventions, and, critically, the essential nursing care and safety alerts. Before we unpack all the statistics and the really complex science, we probably need a shared clinical vocabulary. Let's just establish a few crucial terms from the glossary that are going to define the landscape we're entering.
Absolutely. First up, obesity itself. The World Health Organization defines it as a disease involving abnormal or excessive body fat accumulation that genuinely impairs health.
It's that impairment to function that's the key part.
Exactly.
And the definitive clinical tool we use to classify that is the BMI, or Body Mass Index. And that's a simple, universally used calculation. Weight in kilograms divided by height in meters squared.
Next is a crucial concept. It's a newer one in the understanding of the disease: adiposopathy.
So this isn't just having fat.
No, this is the dysfunction of adipose tissue. It's what leads to the chronic inflammation and then all the subsequent systemic diseases we see.
And when we talk about treatment, the whole field is often called bariatric, which I think comes from Greek words.
Yes, it does. Yeah, it means weight and treatment. Very straightforward.
Okay, and one last one that's a huge deal for post-surgical care.
Right. Dumping syndrome. Sometimes it's called vagotomy syndrome. It's this acute, really unpleasant physiological response that happens when undigested food rapidly empties from the stomach into the jejunum.
And that causes systemic symptoms.
Oh, yeah. Nausea, weakness, palpitations, sweating. It's a big deal.
But that really clarifies the key concepts we'll be referencing. The single biggest shift in how we approach this disease really came in 2013 when the American Medical Association officially recognized obesity as a disease. Why was that so monumental?
It was a complete game changer. It mandated a change in clinical perception. The AMA based its decision on the standard criteria for defining a disease, that it impairs normal function, it has characteristic signs, and it causes significant morbidity.
So it moved it out of the realm of being a personal failure?
Exactly. It moved it away from being viewed purely as a lifestyle choice, which is a source of incredible stigma, to being seen as a chronic, relapsing disease process that is amenable to medical and surgical intervention. That clinical shift informs, well, everything we're about to discuss.
Okay, let's unpack the true scope of this public health challenge.
Let's do it.
When we examine the epidemiology, the scale of this problem immediately justifies why the AMA made that disease designation. The burden is massive globally.
It is truly a pandemic. We are looking at over 650 million adults worldwide who have obesity, and nearly 2 billion are classified as overweight. The rate of increase is just staggering.
Wow.
Since 1975, the global prevalence has more than tripled for men and more than doubled for women. This isn't just about a few populations. It's a systemic global change.
And when we zero in on the U.S. statistics, the figures are even more sobering.
The prevalence here is exceptionally high. We estimate that 42.4% of American adults have obesity, and if you include those who are simply overweight, that figure jumps to a vast majority, 70.9% of the adult population.
The source material provides some critical data in Figure 42:1, and it highlights these demographic variations. It's not evenly distributed.
Not at all. The prevalence is significantly higher among African Americans and Hispanics compared to whites or Asian Americans, and there's a clear link to socioeconomic disparity.
So less education, less income.
Statistically more likely to have obesity. This tells us this isn't purely a matter of individual biology. It is deeply intertwined with systemic access to resources, education, and, healthy environments.
And the resulting functional and economic consequences are just impossible to ignore.
The economic drain is huge. Annual healthcare costs tied to obesity are around $190 billion in the U.S. alone. But look at the functional impact.
Like military readiness.
Exactly. Being overweight or obese is the primary medical reason young American adults are excluded from military service. When nearly half your population struggles with weight, it has profound consequences across every single sector of society.
Okay, let's move on to the risks. This is where we see the full force of obesity as a multi-system disease.
It certainly is. And while obesity alone might not always decrease lifespan, when you couple it with metabolic disease or a chronic illness,
That's when it becomes an accelerant for mortality.
it incurs a much greater overall risk of mortality, leading to an associated 2 to 6 year decrease in overall life expectancy. We really need to walk through the list of associated morbid conditions. It spans every system in the body. Figure 42:2 and chart 42:1 really lay it out.
So let's look for patterns in those conditions, maybe starting with the highest risk categories, cardiovascular and metabolic.
Those are the classic risks. We see coronary artery disease, heart failure, hypertension, hypercholesterolemia. But the most striking statistic for me relates to type 2 diabetes.
What's the number there?
Obesity increases the likelihood of developing it by tenfold.
Tenfold. That's not a marginal increase.
No, it's an exponential risk. And it's driven by that chronic inflammation we mentioned earlier.
And the oncology risks are also really profound.
Yes, obesity is a risk factor for numerous cancers: breast, colorectal, esophageal, pancreatic, kidney, thyroid. We estimate it accounts for up to 90,000 cancer deaths annually.
And the mechanisms for that link back to the inflammation and hormones.
Exactly. Chronic inflammation and altered hormone profiles. It's especially relevant for hormonally driven cancers like breast cancer.
The impact on the respiratory system can be acutely dangerous, especially during medical surgical care.
Oh, absolutely. Pulmonary function is often compromised, leading to obstructive sleep apnea, or OSA. That's a huge risk factor. And also asthma and higher rates of respiratory infections.
And neurologically.
The risks include anxiety, depression, stroke, and adults with obesity are twice as likely to eventually develop Alzheimer's disease.
Wow.
It suggests a really deep connection between metabolic health and brain health.
Finally, there's the mechanical and structural burden on the musculoskeletal and GI systems.
Right, the sheer weight stresses the joints. That leads to accelerated osteoarthritis and chronic low back pain. In the abdomen, we see increased rates of gallbladder disease and, most concerningly, non-alcoholic fatty liver disease, or NAFLD.
And that can progress to cirrhosis, right?
It can, and even liver failure. It truly is a chronic multi-organ failure driven by that adipose tissue dysfunction.
That leads us directly to the question of pathophysiology. If it's not just a matter of willpower, what are the underlying biological drivers of this massive energy imbalance?
Well, at its core, the immediate mechanism is pretty straightforward. Caloric consumption exceeds caloric expenditures over the long term.
But the reasons for that are the complex part.
Right. They're deeply complex, encompassing genetics, hormones, environment, and cellular function.
And that central concept for connecting obesity to disease is adiposopathy.
Precisely. With excessive fat accumulation, the adipose tissue becomes dysfunctional. The cells get too big, they struggle to store fat safely, and they become inflamed.
So the fat tissue itself is sick.
It is. This adiposopathy releases pro-inflammatory biochemical mediators. It's these persistent, low-grade inflammatory changes that promote heart disease, diabetes, and cancer. The fat is broken, and that broken fat damages the entire system.
Let's touch on the genetic component. We used to hear about the thrifty gene hypothesis, but the sources indicate modern genetics paints a much more complicated picture.
Oh, it's highly complex. We now recognize it's a polygenic explanation. Researchers have identified over 700 possible mutated genes.
700.
And each one contributes a small amount, a few pounds of body fat, to the total picture. Take the FTO gene variant, for example. It's not just linked to body composition, but specifically to behavior.
How so?
People with that variant tend to consume more daily meals, more snacks, and they gravitate towards higher fat and sweet foods. So the genetics predisposes them to behaviors that thrive in our modern environment.
That intersection with the environment is crucial. We've really created an obesogenic environment.
That's the perfect term for it. Our modern food system, with all the processed foods high in fructose corn syrup, simple sugars, or trans fats, it's hypothesized to be obesogenic because these foods can bypass normal satiety signals and even trigger addictive cravings.
So they create a physiological drive to eat more.
Exactly, even when the body doesn't actually need the energy.
And the physical act of eating has changed so dramatically, the sources specifically call out portion distortion.
It's such a key environmental factor we've all normalized. Portions of entrees and desserts in fast food restaurants have increased exponentially over the past 30 years.
So it subtly recalibrates what we think is a normal serving size.
It does. It constantly overwhelms our internal cues and promotes hyperconsumption without us even realizing it's happening.
Let's delve into the hormonal signals, the orexigenic versus satiety mechanisms, because these are specifically targeted by both drugs and surgery later on.
Right. This is a fine balance managed by the hypothalamus. Orexigenic signals are the ones that stimulate appetite.
And the key players there.
The two main ones are ghrelin, which is secreted by the stomach and is often high when you're fasting, and neuropeptide Y, or NPY, from the small intestines. They signal the brain to start eating.
And the satiety-promoting hormones that tell us to stop.
We have somatostatin, cholecystokinin, or CCK, which also slows down gastric motility and insulin. But the most famous one, secreted by the fat cells themselves, is leptin.
Ah, leptin, which is supposed to signal satiety.
It is. It's supposed to signal long-term energy sufficiency.
Which brings us to the leptin paradox. This seems like a really cruel biological twist.
It's the reason weight regain is so frustratingly common. Patients who achieve significant weight loss experience a drop in their leptin levels that, well, it persists for the long term.
So it's not just a short-term thing.
No, it's long after the initial weight loss phase. This persistent low leptin creates constant elevated feelings of hunger. Essentially, the body is fighting to restore its previous higher fat mass set point. It makes weight maintenance an endless hormonal battle.
And finally, we have to look at the emerging, really fascinating role of the gut microbiome.
This is one of the most exciting areas of research. The gut contains up to 100 trillion microbes. And what we know is that patients with obesity tend to have less diverse microbiota compared to normal weight individuals.
And this lack of diversity has clinical implications beyond just digestion.
Absolutely. Less diversity is linked to dyslipidemia, impaired glucose metabolism, and it contributes to that low-grade inflammation we see in adiposopathy.
And our diets affect this.
Definitely. Our typical Western-style diets, high in processed foods, fat and sugars, and low in fiber, are thought to negatively affect this diversity. Specifically, they decrease bacteroideate species, which are generally associated with a leaner metabolic type. Future treatments will undoubtedly target regulating this microbial ecosystem.
Moving from the global scale and cellular mechanisms to the individual patient, the assessment and diagnosis phase begins not with a scale, but with the nurse's own self-reflection.
This is the most critical first step. You, as a nurse, must actively confront your own unconscious biases. Research confirms that many healthcare providers hold negative attitudes, viewing patients with obesity as lazy or lacking personal responsibility.
And that stigma has real consequences.
It absolutely does. It directly results in increased depression, lower self-esteem, and critically, it leads to the patient avoiding future healthcare appointments.
So the immediate strategy to counter this is using patient-first language.
Exactly. Instead of describing a patient as the obese patient, which defines them by their disease, we say, the patient with obesity. It's a subtle but powerful shift that acknowledges the person first and treats the condition as an illness.
Once that respectful foundation is established, the key history components require a really comprehensive look at the patient's entire life and medical timeline.
You have to get a thorough history, identify the duration of obesity. Was it since childhood or did it start post-pregnancy? Assess family history. You need to detail all prior successful and unsuccessful weight loss strategies to understand what interventions have failed and why.
And, of course, a detailed analysis of exercise and diet.
Right. And two other huge factors, sleep and medications.
Sleep pattern disturbances can point to obstructive sleep apnea.
A major component. And the medication review, which is highlighted in Chart 42-2, is a crucial nursing responsibility because so many common medications are obesogenic.
Let's leverage the insight from that chart, focusing on the patterns of the weight gainers.
We see clear patterns in drug classes. Think about the psychotropics. Anticonvulsants like valproate, certain SSRIs like paroxetine, and especially the antipsychotics like olanzapine and quetiapine are notorious for causing weight gain.
What about diabetes meds?
Yes. Insulins, sulfonylureas, and thiazolidinediones often promote weight gain, which can actually exacerbate the underlying metabolic issue they're meant to treat. And of course, hormones like corticosteroids are on this list.
Conversely, some medications offer a significant advantage by promoting weight loss while treating the underlying condition.
This is where we see true clinical synergy. For instance, the anticonvulsants, topiramate or zonisamide. In diabetes management, metformin and the GLP-1 agonists like semaglutide or liraglutide are often preferred because they aid in weight reduction.
So this gives us a clear clinical application point. A nurse needs to be aware of this pharmacologic nuance.
Absolutely. If your patient needs medication for both obesity and type 2 diabetes, advocating for a GLP-1 agonist or metformin provides much better clinical outcomes. This knowledge can influence the entire management plan.
Okay, the next phase is the hands-on physical assessment. This starts with accurately measuring height and weight to calculate the BMI.
Right, and BMI remains the definitive classification tool. Table 42-1 lays it out clearly.
Let's just quickly define those crucial classification thresholds.
Sure. Overweight or pre-obese is 25 to 29.9 kilobarometer Marts. Class 1 is 30 to 34.9. Class 2 is 35 to 39.9. And then the highest risk group, Class 3, often called severe or extreme obesity, is anything above 40.
To make that threshold of Class 3 tangible, a BMI of 40, if you're caring for a patient who is 5'8" tall, they would need to weigh 262 pounds to hit that number.
Right, that really demonstrates the weight burden. But beyond BMI, you have to perform detailed anthropometric measures, specifically waist circumference and the waist-to-hip ratio, because where the fat is stored is just as important as how much fat there is.
The critical threshold for high risk in waist circumference is what again?
Greater than 35 inches for women and greater than 40 inches for men. If a patient crosses this, they automatically enter a higher morbidity risk profile.
And that leads to the calculation of the waist-to-hip ratio, which helps differentiate the two body shapes that we see in Figure 42-4, the apple and the pear shapes.
Exactly. Android obesity, or the apple-shaped distribution, is when the fat is around the trunk.
And that's associated with more dangerous visceral fat.
Correct. The fat stored around the internal organs. This visceral fat is far more metabolically active and puts the patient at a significantly higher risk for hypertension, coronary artery disease, stroke, and type 2 diabetes.
Whereas gynoid obesity, the pear-shaped body, has fat distributed below the waist and hips, and that carries a much lower overall metabolic risk.
Much lower risk profile, yes.
Finally, we turn to the diagnostic evaluation, ensuring we screen for all the comorbidities that result from this disease state.
Right, so standard lab studies are essential. You screen for cardiovascular risk with cholesterol and triglycerides, for diabetes with fasting blood glucose and HbA1c, and given the epidemic of AFLD, you have to check liver enzymes, AST and ALT.
And given that obesity is the single most important risk factor for obstructive sleep apnea, or OSA,
Diagnostic sleep studies are warranted for any patient reporting sleep disturbances. The nurse needs to assess carefully for things like daytime sleepiness or loud snoring.
and a quick note on ruling out secondary causes.
Good point. Occasionally, weight gain is secondary to endocrine disorders like hypothyroidism or Cushing's syndrome. In those cases, treating the underlying disorder is the primary intervention, and the weight issue may resolve on its own.
So now we're in the management phase, and we start with the least invasive methods. The first line of approach is always lifestyle modification.
Always. You're targeting both weight loss and, critically, maintenance. The clinical strategy is clear. High-intensity, multi-component behavioral interventions are needed for adults with BMIs over 30.
And the U.S. Preventive Services Task Force recommends intensive behavioral therapy, or IBT. What does intensive actually look like?
It's a significant commitment. We're talking 12 to 24 sessions annually. That includes counseling on diet, physical activity, goal setting, and self-monitoring.
And the patient needs to understand that even modest change can have a big impact.
That's a huge teaching point. You have to reinforce the fact that achieving a weight loss of just 5% of total body weight can yield measurable, significant clinical benefits in things like blood pressure and blood sugar control.
The mechanism for achieving that 5% is fundamentally dietary caloric reduction.
Right. We aim for a caloric deficit of 500 to 1,000 calories daily from their baseline intake. This should result in that target 5% to 10% weight reduction within about 6 months. It's a marathon, not a sprint.
When you as the nurse are counseling patients on the type of diet, what principles should you advocate for?
The focus has to be on quality, not just quantity. Healthy diets emphasize very few processed foods, severely limited sugars, low trans fats, and a heavy emphasis on high-fiber plant-based foods.
And the sources mentioned the DAH diet and the Mediterranean diet as excellent non-commercial options.
They're strong models. The DASH diet, which was originally for hypertension, promotes low-fat and carbohydrate intake. The Mediterranean diet is rich in fiber and healthy fats. They both provide a solid foundation for sustained healthy eating.
Chart 42-4 gives some highly specific, actionable advice for nurses to share with patients. Let's detail those practical strategies.
This is all about managing the environment. First, patients need to actively track their daily food intake. Self-monitoring increases accountability. Second, they have to limit or eliminate the high-risk items. Processed foods, high-caloric beverages, fast foods,
And the behavioral strategies around how we eat are just as important as what we eat.
crucially important. Patients must be encouraged to reduce portions using smaller plates. They need to schedule and plan meals, pre-pack lunches, and eat at home more. And a fundamental rule is avoiding screen time while eating. That just promotes mindless overconsumption.
Okay, moving to the other side of the energy balance equation. Physical activity. The target can seem pretty challenging for sedentary patients.
The general recommendation for optimal health is at least 150 minutes of moderate intensity aerobic exercise or 75 minutes of vigorous intensity aerobic exercise weekly, plus muscle strengthening exercises twice a week.
But the clinical starting point has to be realistic.
Oh, absolutely. For a previously sedentary patient, the best advice is simply to start small. Just 10 to 20 minutes of daily physical activity, like walking, can dramatically improve exercise tolerance and start creating that caloric deficit. The nursing focus is adherence and consistency, not immediate high performance.
Finally, we integrate healthy sleep habits.
Right. Sleep deprivation is a physiological stressor that's hypothesized to increase cortisol levels, which promotes weight gain. So you counsel patients to aim for at least 7 hours nightly, ensure a dark, relaxing environment, and avoid caffeine after lunch.
When lifestyle modifications alone aren't enough, or when you're dealing with a high BMI and comorbidities, the next step is pharmacologic therapy.
Right. Medications are indicated for patients with a BMI greater than 30 or a BMI greater than 27 if they have a concomitant-like type 2 diabetes or hypertension.
But it's crucial to stress that these medications are not a replacement.
No, they supplement diet modification and exercise. They are an adjunct therapy.
The medications work through two main mechanisms of action.
That's right. They either inhibit GI fat absorption, which reduces your net caloric uptake, or they target central brain receptors in the hypothalamus to enhance satiety and reduce cravings.
Before we get into specific agents, the quality and safety nursing alert regarding reproductive health is critical.
This is a non-negotiable patient teaching point. Most anti-obesity medications carry a teratogenic risk, so women of childbearing age seeking these prescriptions must be advised about the necessary need for effective contraception and avoidance of pregnancy while on this therapy.
Let's delve into the specific agents from Table 42.2, focusing on the mechanism and the essential nursing considerations. Let's start with the absorption inhibitor, orlistat.
Okay, orlistat works by diminishing intestinal fat absorption. The major side effects are pretty visible and can be embarrassing for the patient. Diarrhea, oily stools, flatus.
So the essential nursing point here is managing those GI side effects, but also supplementation.
Yes, because fat absorption is inhibited, so is the absorption of fat-soluble vitamins A, D, E, K. Patients must take a daily multivitamin, usually several hours before or after the orlistat dose. And we also caution its use in patients with pre-existing gallbladder or renal issues.
Next, let's look at two central appetite modulators, lorcaserin, a selective serotonin receptor agonist.
This stimulates satiety centrally. Side effects include fatigue, dizziness, and nausea. The nurse has to monitor for cognitive changes, hypoglycemia if the patient is diabetic, and importantly, screen for use of other serotonergic drugs like certain antidepressants or migraine meds.
Because of the risk of serotonin syndrome.
Right. It's rare but very serious.
And then there are the very popular GLP-1 receptor agonists, like liraglutide.
These are incretin mimetics that dramatically delay gastric emptying, which strongly curbs appetite and improves glycemic control. The crucial nursing point is that administration is a daily subcutaneous injection, so it requires patient adherence to technique.
And there are some serious potential side effects.
There are. These drugs have been associated with pancreatitis and thyroid tumors in animal models, so patients need to be aware of those risks.
We also have the sympathomimetic amines, like phentermine, which have been around for decades.
These are CNS stimulants that suppress appetite. The key nursing consideration is the duration. They are only approved for short-term use, a maximum of 12 weeks. Tolerance develops and weight is often regained when they're stopped.
And they're contraindicated for a lot of patients.
Strictly contraindicated in patients with existing heart disease, uncontrolled hypertension, or hyperthyroidism due to their stimulant effects.
Finally, the newer synergistic dual agents.
Right, these combine mechanisms for an enhanced effect. You have Fentermint Pyramid ER, where the nurse has to monitor electrolytes for hypokalemia and metabolic acidosis. And then you have naltrexone bupropion, which addresses cravings and appetite, but is contraindicated in patients with uncontrolled hypertension, epilepsy, or a history of eating disorders.
Beyond drugs, the field is developing specialized non-surgical interventions that offer alternatives to major bariatric surgery. Let's start with vagal blocking therapy, or V-blocker.
This is a form of gastric stimulation. A pacemaker-like device is implanted with leads at the gastroesophageal junction where the vagus nerve is. For 12 hours a day, it intermittently delivers a blocking signal to that nerve.
And what are the results of blocking that nerve?
It's multi-pronged. It diminishes gastric contractions, it limits the secretion of ghrelin, and it decreases pancreatic enzyme secretion. All of this leads to increased satiety and reduced caloric absorption.
And patient education involves charging the device.
Yes, you have to teach them how to use an external coil to recharge the unit twice a week for about an hour.
Next, there's the purely mechanical method, intragastric balloon therapy.
This involves the temporary endoscopic placement of a gas or saline-filled balloon into the stomach, where it stays for 3 to 6 months. It just takes up space, promoting satiety. Nausea and vomiting are common initially.
But the sources highlight a critical safety alert here that nurses must convey.
This is absolutely vital. Before insertion, these balloons are impregnated with methylene blue dye. If the patient reports green urine, that is the unmistakable sign that the balloon has ruptured.
And that requires timely removal.
Immediately, because a deflated balloon poses a high risk of causing an intestinal obstruction. So patients who can't commit to follow-up are poor candidates for this.
And finally, a glimpse into the future. Endovascular bariatric embolization.
This is currently in clinical trials, and it's a really elegant, minimally invasive concept. The gastric fundus secretes about 90% of ghrelin, the appetite stimulant. So the procedure uses microspheres embolized via the left gastric artery to block blood flow to that area.
The goal being to just shut down ghrelin production.
Exactly, to diminish ghrelin secretion and achieve sustained weight loss without a surgical incision. The preliminary data is promising.
We know obesity management is not one size fits all. We have to tailor our approach to specific populations, starting with gerontologic considerations.
Right. Obesity prevalence in adults 60 and older is high, about 42.8%, and aging brings physiological hurdles. Decreased lean muscle mass, increased adipose tissue, and a roughly 2% drop in basal metabolism per decade.
So the body requires fewer calories and gains weight more easily.
That's right. And for older adults with obesity, they face increased risks of falls, severe mobility impairments, and cognitive dysfunction.
But the source notes that merely overweight older adults may not be counseled for weight loss.
Correct, if they are otherwise healthy. But those with obesity, a BMI over 30, must engage in lifestyle modifications.
So the nursing focus shifts heavily to calorie quality.
Yes, to ensure nutrient density. We emphasize limiting fats, ensuring adequate protein to maintain muscle mass, and increasing soluble fibers. You also have to tailor advice to functional barriers. If a patient struggles to chew, recommending protein drinks is more effective than demanding raw vegetables.
What about bariatric surgery in seniors?
There's an ongoing debate, but contemporary research indicates that older adults who undergo bariatric surgery can have comparable outcomes and complication rates to younger patients. Age alone shouldn't be an automatic exclusion.
Next, the significant data related to veterans' considerations. Despite strict recruitment standards, weight issues profoundly affect the military and veteran communities.
The rate of obesity and overweight among service members has tripled in 20 years. In 2019, it was at 17.4%. This creates massive challenges for operational readiness.
But the greatest risk seems to happen after they leave the service.
Absolutely. Within 6 years of leaving the military, 36% of normal weight veterans became overweight, and 26% of those who were overweight became obese.
And that's attributed to the loss of mandated fitness standards and the environment.
Yes, 89% of veterans live in areas with limited access to healthy food or fitness facilities.
The good news is that specific lifestyle factors were identified that could mitigate this weight gain.
Right, and these factors align with the VA-MOVE program. Consistent activity, limiting sedentary time, limiting fast food, getting enough sleep, not smoking, and moderate alcohol intake. These are tangible, teachable goals.
Finally, the critical health event of the last few years forces us to address COVID-19 considerations.
Obesity emerged very early in the pandemic as an overwhelming risk factor for severe COVID-19. The data is definitive. Obesity is associated with prolonged hospitalization, increased need for critical care admission, and overall poorer outcomes.
It really exemplifies how obesity impairs the body's ability to cope with acute external stress.
Perfectly said.
Now we transition entirely to the nurse's responsibilities when caring for patients with obesity in the medical surgical setting. And we have to start again with that persistent issue of stigma and care avoidance.
You have to remember that stigmatization, even subtle actions or language, exacerbates depression and low self-esteem, leading to care avoidance. Your care must be centered on the disease process, not on judgment.
Let's review the system-specific physiological challenges we see in patients with class 3 obesity, starting with respiratory compromise.
The anatomic remodeling, increased neck circumference, larger chest diameter, makes these patients prone to OSA, respiratory failure, and obesity hypoventilation syndrome, or OHS.
Which is daytime hypoventilation, high CO2, low oxygen.
Exactly. It requires intense monitoring.
So what are the immediate practical nursing interventions to maximize respiratory function?
Positioning is key. You maintain the patient in a low Fowler position to maximize diaphragmatic descent. Standard interventions include continuous pulse oximetry, supplemental O2 as needed, and frequent respiratory assessments. And if the patient has known OSA, strict compliance with their prescribed CPAP or BiPAP is a life-saving nursing priority.
In terms of circulatory compromise, we see higher rates of heart failure and hypertension, but the practical nursing challenge is just getting an accurate reading.
Measurement accuracy is critical. You must use an appropriately sized blood pressure cuff. A cuff that's too small gives you a falsely high reading and can drive unnecessary interventions.
And we also have a higher VTE risk.
A significantly increased risk for VTE, yes. And the mechanical difficulty of IV access cannot be understated.
It's a huge challenge.
It is. Blind stick attempts fail frequently. The current standard is moving towards utilizing ultrasound guidance to successfully gain peripheral IV access in these patients. It minimizes trauma and speeds up necessary treatments.
The highest level complexity for the med-surg nurse is often pharmacokinetics and pharmacodynamics. How does body composition complicate drug dosing?
The extensive adipose tissue alters the drug's journey through the body. Some medications are highly lipophilic. They love fat, so they bind readily to adipose tissue, essentially inactivating the drug or prolonging its effect. The bottom line is that dosing recommendations change drastically.
Let's contrast two examples. Norepinephrine versus opioids.
Okay. For critically ill patients with sepsis, research suggests they may require lower proportional weight-based dosages of IV norepinephrine. But conversely, for pain relief, patients with obesity frequently require higher dosages of opioids to achieve effect.
Yet they're simultaneously at a higher risk for sedation and respiratory depression.
Exactly. It's a very fine line to walk.
So the nursing imperative here is collaboration.
Absolutely. Never rely solely on standard weight-based calculations. Nurses must collaborate with clinical pharmacologists and primary providers for every drug dosage adjustment to navigate this safely.
We also have to address skin and mobility. The increased adipose tissue itself diminishes blood supply, oxygen, and nutrients, making these patients acutely vulnerable to pressure injuries.
That vulnerability is compounded by moisture and friction in skin folds, under the breasts, in the abdomen, in the gluteal folds, and immobility is a huge risk factor.
What are the specific nursing interventions for skin integrity and safety?
A WOC nurse consultation is highly advisable. You must use specialized durable medical bariatric equipment for transfers, lifts, transport equipment, and strictly enforce safe patient handling protocols to prevent staph injury.
And the old turning schedule might not be enough.
The traditional every 2 hours protocol is often insufficient. You need to encourage more frequent patient movements and ensure meticulous skin inspection and hygiene, especially in those dependent folds.
When non-surgical attempts fail, we move to bariatric surgery procedures. The selection criteria in Chart 42-6 are very strict.
They are. Surgical treatment is reserved for those who meet specific criteria. A BMI over 40 without excessive surgical risk, or a BMI over 35 with one or more severe comorbidities like OSA or debilitating arthritis, or a BMI over 30 with type 2 diabetes and poor glycemic control.
And the inclusion and exclusion criteria emphasize the need for lifelong adherence.
Patients have to demonstrate the ability to commit to lifelong follow-up and dietary changes. Exclusions include current substance use disorder, uncontrolled psychiatric illness, or a patient who just can't fully comprehend the severe risks and commitment involved.
Let's review the 4 main procedure types from Figure 42-5.
We classify them by mechanism: restrictive, malabsorptive, or both. The current most common procedure is the sleeve gastrectomy. It's restrictive only. 85% of the stomach is removed, leaving a vertical sleeve.
The second most common is the combined approach.
Right, the Roux-en-Y gastric bypass, or RYGB. It's both restrictive and malabsorptive. It creates a tiny 20-30 millivala pouch and bypasses most of the stomach and duodenum. This alters hormone signals, making it very effective for type 2 diabetes.
The procedure that yields the most weight loss is the biliopancreatic diversion with duodenal switch.
This is reserved for very high BMIs because it is highly malabsorptive and involves extensive intestinal rerouting. And finally, gastric banding is restrictive, but less common now due to higher rates of band failure.
So let's talk about the nursing process for these patients. It begins preoperatively. What specific assessments are needed to ensure surgical readiness?
The preoperative screening has to confirm adherence readiness and rule out contraindications. The nurse ensures all baseline labs are complete: CBC, electrolytes, BUN, creatinine, and that screenings for comorbidities are finished, like sleep studies, endoscopy, ECG, and a crucial check for baseline vitamin deficiencies, particularly iron and B12.
Postoperatively, the assessment shifts to monitoring for those high-risk bariatric complications.
Exactly. The potential for severe problems dictates the whole planning phase. We're talking hemorrhage, VTE, bile reflux dumping syndrome, and the most feared one, the anastomotic leak.
So the goals are numerous, but centered on stability and education.
Right. Infection prevention, fluid balance, pain relief, and adherence to that lifelong detailed diet plan.
Let's detail the core interventions, starting with fostering patient knowledge.
Education is constant. It covers the procedure, nutrition, activity. You counsel patients to join support groups both pre- and post-operatively. In pre-op, patients are usually on a clear liquid diet for 24 to 48 hours to shrink the liver and prepare for surgery.
The postoperative diet progression is arguably the most critical teaching for nurses to enforce. Adherence directly prevents complications.
It is so critical. The progression is slow and deliberate. Clear liquids for 48 hours, then moving to full liquids, which must be sugar-free or low sugar, then progressing to a pureed diet, then soft solids, and only reaching solid food by about 8 weeks post-op.
So nurses need to educate patients to stock their kitchen before surgery.
Yes, with sugar-free drinks, protein supplements, and low-fat soups.
How do we manage relieving pain in this high-risk population while mitigating the risk of opioids?
The strategy favors non-opioid agents like acetaminophen. Immediate-release oral opioids should be strictly limited, often to no more than 15 doses postoperatively. You want enough pain control to allow mobilization, but you have to minimize that respiratory depression risk. Positioning in a low or high Fowler position also helps promote comfort and gastric emptying.
Ensuring fluid volume balance starts with IV fluids, but quickly shifts to the patient's oral intake.
Once they're cleared, the patient starts with very small sips, 30 milliliters every 15 minutes of sugar-free fluids. Avoiding sugar is crucial to prevent triggering dumping syndrome, and you have to give antiemetics proactively to prevent vomiting. Retching creates massive strain on that surgical staple line.
And the anastomotic leak is a life-threatening emergency. What are the signs the nurse must prioritize?
The signs are insidious and often nonspecific: fever, generalized abdominal pain, persistent tachycardia, and leukocytosis. High-risk patients are older males with higher BMIs. If it progresses, it leads rapidly to sepsis and septic shock. You have to maintain a high index of suspicion.
Long-term, ensuring adequate nutritional status requires a total behavior change.
After bowel sounds return, the diet resumes with 6 small feedings totaling only 600 to 800 calories per day. Patients must learn to eat slowly, chew thoroughly, like 20 to 30 chews per bite, and stop immediately when they feel full.
Chart 42-7 provides the crucial lifelong dietary guidelines. Let's walk through the specifics a patient needs to know for long-term adherence.
Okay. The food must be high in protein and fiber, with strict avoidance of concentrated carbohydrates. The meal size is tiny, no more than 1 cup. The crucial behavioral intervention is positioning. Patients must assume a low Fowler position during and for 20 to 30 minutes after meals. This uses gravity to delay stomach emptying and decrease the risk of dumping syndrome.
And there's that strict rule regarding fluid intake.
Absolutely strict.
Yeah.
Avoid drinking fluid with meals. You wait 30 minutes before a meal and 60 minutes after a meal to consume liquids. This prevents rapid gastric distension and premature washout of the food.
Finally, we must proactively manage nutritional deficiencies.
You monitor for malabsorption of organic iron, which may require supplementation. Critically, vitamin B12 malabsorption is common after RYGB and other malabsorptive procedures, so that necessitates lifelong, monthly intramuscular B12 injections to prevent pernicious anemia.
And the psychological aspect of supporting body image changes is essential, even when the surgery is a success.
Yes. While most patients report high satisfaction, nurses must acknowledge that body image dissatisfaction remains, often related to large, loose skin folds. Referrals to support groups, counseling, and discussions about elective body contouring surgery should be part of the care plan.
We have to finish by detailing the management of specific complications the nurse must anticipate. First, change in bowel habits.
Diarrhea is common, particularly after malabsorptive procedures, and is managed by encouraging a high-fiber diet. Steatorrhea, or fatty stools, may require reducing dietary fat intake or using anti-motility meds.
Regarding hemorrhage, the timing helps identify the cause.
Right. Most common the first 72 hours, usually from staple line disruption. Bleeding occurring 72 hours to 30 days post-op is more likely caused by an ulcer. The signs of hemorrhagic shock tachycardia, hypotension, syncope demand, immediate attention.
Given the increased risk, VTE prevention protocols are critical.
Bariatric surgery is high risk for VTE. ASMBS guidelines mandate both interventions: mechanical compression, like pneumatic devices, anti-prophylactic anticoagulation with subcutaneous low molecular weight heparin, and you have to encourage early aggressive ambulation.
Dumping syndrome requires us to revisit its dual symptom phases.
Right, recall the physiology. Rapid transit triggers a massive release of metabolic peptides. Early symptoms within minutes to 2 hours are vasoactive tachycardia, dizziness, sweating, nausea. Late symptoms, 10 to 90 minutes later, are purely metabolic reactive hypoglycemia, so they get pallor, palpitations, headache, drowsiness. Strict adherence to the dietary rules is the best prevention.
Dysphagia, difficulty swallowing, is a common transient symptom.
It peaks 4 to 6 weeks post-op. Patients have to be educated rigorously to eat slowly and avoid foods prone to causing obstruction. Those are typically tough, dry, or doughy things like steak, dry chicken breasts, or bread.
Finally, we arrive at the most critical, life-saving safety alert in this entire deep dive: managing potential bowel and gastric outlet obstruction.
This cannot be overstated, and every single nurse must know it. There is a critical safety alert. Insertion of a nasogastric or NG tube is absolutely contraindicated in patients post-bariatric surgery.
Even if they present with signs of obstruction.
Even then,
What is the inherent immediate danger of inserting an NG tube here?
blind insertion risks disrupting the fresh surgical staple line or suture line. That is the direct cause of high mortality complications, like an anastomotic leak or hemorrhage. The nurse must communicate this contraindication immediately to any new provider. If an obstruction is suspected, alternative treatments like endoscopic balloon dilation or surgical revision must be performed. No NG tubes.
Got it. Okay, so promoting transitional care and evaluation?
Transitioning the patient home requires detailed education. Discharge instructions have to cover the specific diet plan from Chart 42-7, appropriate exercise, and the instruction to avoid all NSAIDs due to the high risk of ulcer formation in that surgically altered stomach.
And we must reinforce the need for lifelong medical oversight.
Lifelong follow-up for weight management, comorbidity monitoring, nutritional status checks, and behavioral support is absolutely mandatory for safety and success.
And one final family planning point.
Women of childbearing age must use contraceptives for at least 18 months post-surgery. This ensures that the body's weight and nutritional status have fully stabilized before attempting pregnancy, which mitigates risk to both mother and child.
The evaluation then measures success against those goals. Improved knowledge, pain relief, fluid and nutritional balance, successful weight reduction, and the sustained absence of those major complications.
So, what does this deep dive really mean for you? The management of obesity is chronic, it's complex, and it requires integrating genetics, hormonal science, environment, and multimodal interventions. Your role as the nurse is central and multifaceted.
First, recognizing that profound risk for weight bias.
Exactly. Practicing patient-first language to maintain trust. And second, you are the gatekeeper of safety in the postoperative phase, meticulously following the slow diet progression, ensuring lifelong supplements, and, as we stressed repeatedly, enforcing the absolute contraindication of NG tube insertion. Precision nursing care is paramount.
We've explored how this disease is rooted in genetics, environment, and hormone imbalances, like that persistent low leptin signal that drives chronic weight regain. We've also highlighted the critical safety knowledge required in the surgical setting. Consider this as you advance your practice. Given the complexity of genetic predisposition and hormonal signaling, how might future nursing interventions shift from broad behavioral modification to personalized medicine leveraging genetic data or targeted microbiome therapies to address the biological drive for weight regain more effectively?
That is the essential frontier for patient-centered care. Thank you for joining us on this essential deep dive into clinical management.
Keep learning, and we'll catch you next time.